Hello, everyone. Welcome and thank you for joining the Interventional Psychiatry Consortium. My name is Yaakov Green. I'm a psychiatry resident at Columbia and one of the organizers of the consortium, alongside Ailani, Jeff Zabinski, and Jarrod, as well as our steering committee. This is a brand new initiative. It was created due to a desire from training programs in interventional psychiatry from across North America to offer their learners robust didactics that fully capture the breadth of this rapidly growing field. And the realization that we can best do so by sharing expertise across institutions by forming an educational network, a consortium. Each year, we will host a series of talks led by experts from our various institutions. The talks are designed to highlight cutting-edge research while also being firmly grounded in clinical practice, and cover the fundamentals while really focusing on advanced topics that would not typically be included in a standard training curriculum. And the consortium is more than a lecture series, it's a shared learning space for trainees. In the coming months, we plan to launch additional formats like case conferences and journal clubs. So this year, we have a phenomenal lineup of speakers covering a variety of topics, as you can see. If you haven't already, please sign up to receive invitations to future events and also take a moment to complete our brief survey. We are thrilled to be hosting our inaugural talk today, led by Drs. Peter Giacobbe and Nick Trapp, on the perfectly apt question to frame this series: what is interventional psychiatry? We'll have 40 minutes of the talk, followed by a Q&A. So over the course of the talk, jot down any thoughts you'd like to share. And during the Q&A portion, we will reopen the chat to receive questions and select them for the speakers. Now I'm excited to introduce our two speakers. Dr. Peter Giacobbe is the clinical head of the Harquail Center for Neuromodulation and the inaugural Kerr Chair in Interventional Psychiatry at Sunnybrook Health Sciences Center in Toronto. He is an associate professor in the Department of Psychiatry at the University of Toronto. Dr. Giacobbe's clinical and research interests focus on the development and evaluation of interventional psychiatry strategies for individuals with treatment-resistant mood and anxiety disorders. He's published over 170 articles and book chapters on the topics of mood disorders and their treatment, and he is passionate about improving education and training methods in the area of interventional psychiatry. Dr. Nick Trapp is a neuropsychiatrist and a neuroscientist at the University of Iowa and Iowa Neuroscience Institute, who specializes in procedural treatments for neuropsychiatric conditions. He is the Penningroth Fellow of Interventional Psychiatry and directs the Interventional Psychiatry program at Iowa. He also co-directs a neuromodulation fellowship and an interventional psychiatry training residency training track, and has published extensively on topics related to interventional psychiatry training. Dr. Trapp's research focuses on clinical and translational projects related to brain stimulation, neuropsychiatry, neuroimaging, and device development. So without further ado, Drs. Giacobbe and Trapp.
Okay, thank you, everyone. It's a real pleasure to be here and start off with what's going to be, looks like an outstanding series of lectures over the next year. Dr. Trapp and I are going to talk about a fundamental topic: what is interventional psychiatry, and hopefully get you excited about the excellent lectures to come. Next slide, please. So here are our disclosures. These are funding sources. None of the funding sources have influenced or provided slides that we'll be presenting today. Next slide. Next slide. Okay, so I think we're going to start off by thinking about our understanding of psychiatric disorders. I think we're going through a paradigm shift in the last decade or so, and now we're considering psychiatric disorders as circuitopathies, disorders of neurocircuits, not dissimilar to other neurological conditions like Parkinson's or epilepsy. And certainly the previous heads of NIMH have championed this point of view. So Tom Insel published in Scientific American about 15 years ago with the promise of psychiatric disorders being disorders of faulty circuitry. And this led to the RDoC approach, which went beyond psychiatric phenomenology to look at fundamental circuits that transcend diagnoses across the board. His successor, Joshua Gordon, kind of doubled down on that vision and said, he championed this, but was also thinking about becoming the idea of circuit psychiatrists. So instead of psychiatrists in the future being depression specialists or bipolar disorder specialists, this paints a picture of us being specialists of certain pathologies, hippocampal volume loss specialists, or DLPFC hypoactivity specialists. And it's a very provocative vision, but it's one that is being championed by the leaders in mental health. Next slide. I think this is something that is gathering popularity. Next slide should be there. Okay, yeah. In terms of the general public as well, and these are a couple of books that have been published recently about, the life of electricity and the electricity of life, and then We Are Electric. I think we've all heard of the microbiome and the genome, but are you ready for the electron? Like how our electrical system interacts with the environment. Next slide. So in psychiatry, we are going through a renaissance in circuit-based therapeutics. I mean, certainly some of our first effective treatments like ECT were circuit-based and interventional. But then with the advent of pharmacology, many people were treated with antidepressant medications as well as obviously psychotherapy. I think we're coming back to the idea that the brain is an electrochemical organ, and by changing medications, we're only looking at half of that equation. So perhaps we can change the electrical properties for therapeutic gain. And we need to do this because despite our best efforts, about a third of patients don't achieve adequate symptom relief from our best evidence-based psychotropic medications and psychotherapies. We're at a time in the development of psychiatry where we've never known more about the brain and neurocircuitry. Our knowledge is not perfect by any means, but it's given us hypothesis-driven targets, which we can then modulate through multiple technologies that we have. And throughout the course of the year, you'll be hearing about a lot of these technologies. Next slide, please. So the objectives of today's talk are really to provide some principles of interventional procedures, specifically brain stimulation as applied to the treatment of psychiatric disorders, to increase your knowledge of the rationale and evidence for these approaches in the treatment of psychiatric disorders, as well as to develop a greater appreciation for the development of the concept of interventional psychiatry over time. I think it's still a concept that's developing, and even the name is contentious in some circles. So we'll talk about, what to call this field. Next slide. Next slide. Okay, so talking about applied neurophysiological principles, there's been excellent work, as mentioned, in terms of advancing our knowledge of the neurocircuitry of psychiatric disorders, such as the work coming from Shannon Siddiqui and his group that looked at, is there a common depression circuit? Is there a circuit that transdiagnostically is associated with depressed mood? And what they did is they looked at brain lesion studies, people with known lesions, stroke, and other types of lesions to the brain with neuroimaging, looked at which parts of the brain where those lesions impinge are overrepresented in people who develop subsequently develop depression, as well as the efficacy of targets in different parts of the brain to improving depression. And what they found was a common dorsolateral prefrontal subgenual cingulate circuit. I think this is something you'll hear much about in the lectures to come, but this seems to be a common depression neurocircuit. We know that to the degree that our treatments are able to modulate activity in the circuit, people will improve. Medications have been shown to change activity in the circuit, psychotherapy as well. So for people for whom those treatments don't work, we have to get a little more invasive, either through top-down stimulation with ECT or TMS, or bottom-up stimulation or deeper stimulation through surgeries. So this is a very provocative and very promising advance. So next slide, please. And so now, how can we impinge and modulate the circuit? Well, we can certainly do it through electrical stimulation. This is the most classical way of doing it, through ECT. But we know that the scalp and the skull resist the flow of electrical energy to the brain. Unless we have a craniotomy, it'll block the and attenuate the energy. And so the spatial localization of the electrical stimulation is not perfect. Also, we need a critical amount of energy to trigger neuronal firing. So this is key. So anything that's subthreshold will not cause any neuronal firing. However, we know that TDCS, and we'll hear about this, I believe, from Dr. Carpenter, can modulate the resting membrane potential without activating neurons. So it can make the neurons more likely or prime them to respond. We could take this knowledge, this growing knowledge about neurophysiology, to improve our treatments. And as a case in point, we know that ECT can be delivered more efficiently with ultra brief pulse, which mimics the chronaxy, what we know about the neuronal response. So you can see here the older machines were sine wave machines, which ramped up the energy, triggered the action potential, and then came down. But there was a lot of red there, a lot of extra energy that was superfluous and associated with more cognitive side effects. So as we know more about the brain, we're tailoring our treatments to make them more effective and to minimize side effects. Next slide. However, to kind of overcome the engineering problem with the scalp and the skull resisting energy, we can deliver magnetic fields, which are able to penetrate the scalp and skull with little resistance, not no resistance, but little resistance. So this offers a greater opportunity for us to control the location where we're stimulating and the extent to a greater degree than ECT. We know that when we do this with TMS at high frequencies, so more than 10 hertz, the area underneath the coil will increase in activity. Whereas if we give inhibitory, it will hyperpolarize the neurons and functionally decrease the activity in that circuit. So what this allows us to do is if we have a condition where a certain part of the brain is underactive, we can stimulate it, whereas if another part of the brain is overactive, we can inhibit it. So it's a very flexible tool with a lot of spatial precision. However, the limitation is it's not able to directly stimulate the deeper parts of the brain. And some studies would suggest that it can stimulate 5 to 6 centimeters into the brain, so cortical areas, but not the deepest parts. Luckily, thankfully, we know the DLPFC is connected to the subgenual cingulate, so we can use that as a waypoint to drive change throughout the brain. This is an approved treatment currently for depression, OCD, and smoking cessation, although in the European Union, there's many other indications for TMS. Next slide, please. So to get to the deepest parts of the brain, which are not precisely accessible to ECT, TDCS, or TMS, we have to use surgery right now. This is a depiction of deep brain stimulation, which involves the implantation of electrodes into the brain to provide ongoing non-convulsant stimulation like a pacemaker. Next slide. Next slide. So here's a depiction of what this looks like, and it allows us to change a number of different parameters. So while the electrode doesn't move, we can say which of the 4 active contacts are on, which can represent different white matter bundles and different parts of the circuit. We change the voltage, frequency, and pulse width. I've been fortunate to be involved in some of the DBS work for about 20 years, and it's still requiring some pivotal studies to demonstrate the superiority of active stimulation, although there's been a lot of advances through Helen Mayberry and others to try to fine-tune the target. Next slide. An alternative is an incisionless type of neurosurgery called MRI-guided focused ultrasound. So this does not involve directly entering the brain with the surgery, but involves the application of energy externally, thousands of ultrasonic beams which are focused to a certain part of the brain, and where that energy converges, it heats it up. And when it heats it up, it causes the lesion. So it does this without cuts. So this is considered an incisionless neurosurgery, still a neurosurgery because it changes the structure of the brain, but it does it without cuts. So there's less risk for infection and other complications. And I think we'll be hearing about this from Stephen Ferber from the Cleveland Clinic in January. Okay, so next slide. So we talked about that we have a number of different tools now, more than ever, to activate and change the activity in the brain therapeutically. So are we at the point as a field where we can think about an interventional psychiatry. Next slide. So I think it's important to reflect that the history of interventional treatments is in fact the history of psychiatry. So this is a very complex history, and I think we'll be hearing about this by Dr. Zabinski in terms of the bioethics of interventional psychiatry, but many of our early treatments were in fact interventional, based off of incomplete and obviously not accurate models of mental illness, including an excess of black bile, melancholia, spirits, and undoubtedly people are going to look back decades or centuries from now and say our knowledge was incomplete. However, the need to intervene and help the person in front of us is part of our human experience. So applying these treatments involves the balance of two medical ethical principles. First, do no harm, and then it's better to offer a treatment with an unknown mechanism than to offer nothing at all. So the need to intervene while doing it within an ethical framework. Next slide. So we're at the point now where we have a number of different treatments, and residents, and such as many of you on the call here, report a desire for more neuroscience-based education. We know that other specialties like cardiology and radiology have developed subspecialties of interventional psychiatry, which have used the constant application of innovative technologies, disruptive technologies at times to enhance outcomes. So taking what we know and the technologies we have and applying them to help the patient in front of us. And this term, was first mentioned in literature by Nolan Williams about 11 years ago, and to describe treatments that are more procedural and invasive than general medical care within that specialty. And others, including Dr. Trapp and I, have published on this and have tried to develop this within a pedagogical framework. Next slide. Okay, so start off with a paper that we did about 4 years ago now, which was a needs assessment of about 150 Canadian residents psychiatry residents who are about to do their licensure in our country. And what we asked them, next slide, is first line treatments like medication, psychotherapy, ECT, and TMS. We asked them, as part of your clinical identity as a psychiatrist, do you feel familiarity with these treatments should be required to become a psychiatrist? So not surprisingly, about 99% of people felt medications. People should know how to use medications, about 95% psychotherapy. 92% of people felt ECT. People should graduate knowing how to do ECT. Despite that, only about 25% of people graduate from their programs with self-reported competence to do ECT. So there's a gap there. The gap doesn't appear to be in teaching. It's more in terms of supervision and experiences delivering it. And also at the time, people, TMS has evolved a lot, but at the time we did the study, only a small minority of people felt they had adequate exposure to TMS. So there's a desire to incorporate ECT, learn more about TMS. And at this point in time, only 3% of people who are graduating knew how to do TMS. I think that number has changed. I hope that number has changed. And certainly with this consortium, we want to drive that further. Next slide. So then fundamentally, the question came up as, what should we call this field? Should we call it neuromodulation? Should we call it interventional psychiatry? In fact, if you look at, the introduction from Yaakov, I was initially appointed as the head of neuromodulation, but now I'm a chair in interventional psychiatry. I think that also kind of reflects the evolution of the field over time. And I think Dr. Trapp will talk about some of the different names, but we did a study where we asked people at U of T, University of Toronto, to say, what do you think about the name interventional psychiatry? Does this capture this field? Most of the people said yes. 89% of people said yes. And then when we asked people, do you do these interventions or not, it was the same response. So even people who don't identify or don't do these treatments felt the name captured this area. And we'll talk about the implications of that and so forth. Next slide. So next question is, okay, if interventional psychiatry captures the name for these procedural care in our specialty, which competencies should be considered? Unanimously, people felt the brain stimulation techniques of ECT and TMS should be a competency. And interestingly, ketamine, IV and intranasal esketamine were also strongly felt to be part of this. So it kind of sets a course beyond brain stimulation. People felt that other treatments that go beyond brain stimulation or neuromodulation should be included, perhaps hence the name interventional psychiatry, which is, again, more about procedural care rather than specific mechanisms. And then there was, next slide, minority of individuals also felt other things should be included, including neurosurgeries, and hallucinogenic psilocybin type treatments, which we'll hear about. And I think we'll have good coverage of these topics. So to summarize, the vast majority of people supported the term interventional psychiatry, even if you're not doing interventional care. 100% agreement that ECT and TMS should be part of this. Next, majority felt that ketamine, which has similar monitoring, should also be part of it. People were supportive of the inclusion of other interventions. And to conclude, this sets a course academically and in terms of our vision for this field to go beyond brain stimulation, to include other things, to be inclusive for other things that are more procedural. Next. Okay, so I have a couple more slides and I'll turn over to Dr. Trapp. So what are the barriers for wider implementation of these treatments? Next slide. So we have a lot of treatments now with good evidence. Why aren't we doing more of this? Both in Canada and US, there's a consistent theme is that lack of training is the main proximal barrier to wider implementation. I know we're concerned about stigma and the tolerability of these treatments, but in fact, from the study from the US, stigma was listed the sixth most important barrier to ECT usage. All the others were lack of well-trained colleagues, lack of champions, space, support, etc. Which is really, we're really thrilled that there's so many people who are interested in this area as the emerging workforce in the area. For those of you who are in residency, you're going to be driving this forward and translating these results to real change at a public health level. Next slide. So with that, I'm going to turn over to my colleague, Dr. Trapp.
Awesome. Thank you so much, Dr. Giacobbe. And first, I'm really excited to see how many people are here attending this, and thanks to Yaakov and everyone else who's spent time putting this together and brainstorming this entire series. I think it's going to be really, really exciting. I'm hoping to attend a lot of these talks myself, just because it's a really neat panel of experts talking about their specialties. So I agree with everything Dr. Giacobbe said, and you'll notice in some of his previous publications, he mentioned this term was coined in 2013, and he was publishing some stuff on this in 2009. So he was doing this before it was cool, and it should really be acknowledged as one of the experts and godfathers of this field. So, the hope is to take a lot of these concepts and not just learn them in isolation and learn, how to use devices, things like that, how to prescribe TMS, but also then to take it to the next level, which is where I think, a lot of times these fellowships and additional training in interventional psychiatry really become useful, which is thinking about clinical decision making and also like integration of these modalities. And so you're going to hear about a lot of these talks as individual modalities, but I want you to be thinking throughout this whole year-long course, about how are you going to apply these to patients? How are you going to think about which different modalities to use in different circumstances? And, some of that will also, I'm sure, get into as we do case presentations on this and things. But that's where I think it really becomes an expert level of knowledge, is how to integrate all of these. So you heard all about these new tools we have, and as Dr. Giacobbe mentioned, we think about TMS and ECT and deep brain stimulation and vagus nerve stimulation. So I'm not saying them in order here, and deep TMS, esketamine, and ketamine. But then it just keeps going, right? Like people start to hear their patients talking about all sorts of things like electrical stimulation, trigeminal nerve stimulation. We've heard about focused ultrasound and photobiomodulation, and can you stimulate the vagus nerve through the ear and through peripheral branches. So this field is just exploding, and there's so many different ways of using these new technologies to interact with the brain. And so I think beyond just learning clinical indications is going to be extremely important, and really what this is going to be rooted in, but also how do you answer questions from patients about these new technologies that maybe don't have as much evidence or maybe have a little bit of evidence, and how you're going to apply them. So even beyond this, we have magnetic seizure therapy you're going to hear about from Holly Listenby, and there's epidural cortical stimulation. There's these new treatments that Dr. Sackheim has pioneered, like FEAST and responsive nerve stimulation and psychedelics. It goes on and on. So we need to think about all these new modalities, but also thinking about, again, thinking beyond maybe even the current indications, because this field is changing so rapidly. So you heard also again from Dr. Giacobbe a lot about these treatments just being the next logical step in care for a lot of patients. There's a lot of people who aren't going to respond to therapy, who aren't going to respond to medications. And so this kind of came about in some ways naturally upon, again, ideas that have been around for a very long time. And so we heard about depression. I think a lot of people think about the STAR-D studies and about how a third of patients would meet criteria for treatment-resistant depression, as we often describe it today, which is usually 2 failed adequate dose duration trials of medications. If you look through other conditions, we have a very similar problem. So OCD, and again, all depends on how you quantify or how you define treatment resistance. But for OCD, that number is at a minimum probably 10% of patients. A lot of patients even have symptoms that partially respond. Bipolar disorder, the chance of not adequately responding is 50% in terms of relapses. Schizophrenia, even clozapine-resistant patients, is about 10% of patients. So you have all these patients that you're going to see in your clinic, especially as an interventional psychiatrist, that you're going to need to think, what do I do next? That's a lot of what I spend my time thinking about, is like, what's the next step if this doesn't work for this patient? And really interestingly, if you look in other conditions like PTSD, and even in some neurologic conditions like epilepsy and multiple sclerosis, the medication-resistant population is actually very similar. Like epilepsy, it's about a third of patients are treatment-resistant. So again, this is a concept that spans not just psychiatry, but also neurology. And I would argue those two are just different sides of the same coin. Here's another table that I really like from an article by Chuck Conway and his team, or multiple others, that takes the STAR-D data and looks at not just those acute remission rates we often comment on, but also multiplies that by following those patients forward, how many of them actually stayed well for an extended period. And it's a little sobering, right? You see, even of the 36% of patients that got an SSRI and responded, only 70% of them remained well. So the probability of sustained benefit was only 25% after that first step. And then you look, that just drops off the map here, especially when you get to, again, 3rd and 4th level treatments, which is part of the reason we define treatment resistance as 2 failed medications. You see the sustained benefit there goes from 13% down to less than 5%. And so again, this just goes, as Dr. Giacobbe mentioned too, beyond our typical psychiatric training. So there's really a need for this specialized training, both in terms of device training, as well as thinking about how to alter our medical decision making to incorporate these new treatments. And there's, I think, this idea, especially in the TMS space, where it's like, well, I can get a device, and then the device manufacturer will train me on the device, and then I know it. And I would argue that that's not enough. That's like, I think Mark George would say that's like buying a car and learning about the car from the dealer, but not ever taking driver's ed. So, you need to actually learn about this from the people that are implementing it clinically. And you can avoid things like this. Here's a lady who's photobiomodulating her dog. Is that clinically indicated? Probably not. You also have a lot of these things that are direct consumer advertised, like transcranial direct current stimulation for gaming. So you can improve your gaming. And, we want to avoid going this route where we go go to the Honey, I Shrunk the Kids phenomenon of experimenting on ourselves. So to kind of recap that, why interventional psychiatry, and our jackets actually in our interventional psychiatry program have an Iowa brain and then say neuromodulation. So we went through the same transition that Dr. Giacobbe did. But really, we have all these new treatment options. There's more and more mounting evidence that we should go to them sooner than we often do. And we need people to be trained in these things. And 3, also, again, just similar facts to what Dr. Giacobbe mentioned related to ECT, which is really, again, the bread and butter of treatment-resistant conditions in many cases in psychiatry. And only about 1 in 400 patients in the US who has depression or bipolar depression will ever even get offered ECT, which is kind of crazy to think about. Not all of those patients would be indicated for ECT for sure, but it's certainly more than 1 in 400. And then also, as we heard about, the number of psychiatry programs that are inadequately or arguably inadequately training residents in these new modalities is sometimes pretty high. About 1 in 4 US psychiatry residencies, at least as of about 10 years ago, didn't even require ECT training. It was kind of an optional thing or a lecture series with no hands-on training. So it's pretty high percentage, and also I hope those numbers are going down over time. And I think this course will contribute to those going down. So standardizing terminology, I agree with what Dr. Giacobbe said. I think there's this idea are things like intensive pharmacology part of interventional psychiatry? I think the answer is yes, and I think sometimes that's actually how we end up with these different terms, like interventional psychiatry versus neuromodulation, which might have different things that fall under those umbrellas. But this is the Interventional Psychiatry Consortium, and so that, in my mind, very much includes intensive pharmacology. And again, there's kind of pros and cons to thinking about those things. I've thought about this a lot from the standpoint of developing like fellowship training for people post-residency, and I think there's some arguments to be made whether a fellowship should require intensive pharmacology. That's something we can certainly talk about and debate later. And in my mind, the difference here really is interventional psychiatry is very specifically in the psychiatric space and includes these other modalities that we use in treatment-resistant patients, whereas often neuromodulation and neurostimulation, in my mind, has more of an implication for brain stimulation technologies and also more interdisciplinary or cross-disciplinary care, where these terms are very common also in neurology and pain management and neurosurgery. And then there's always the question of psychedelics. And I think there's us who maybe sometimes think, yeah, it should be in there. And if you talk to some like psychedelic psychotherapists, they're like, no, that's totally different than interventional psychiatry. So I think there is a lot of debate around these. We published this paper just last year going through a bunch of subspecialty names that had been considered in different programs and in different places, and you'll see these names often still part of institutions, but you guys can read the paper to look at what we listed very granularly, what are the strengths and limitations of these different names. But interventional psychiatry, I think, is one of the most common, especially now. I made this map 6 years ago when we were starting our interventional program at the University of Iowa, just to say, okay, what are people calling themselves in 2019? And this was the map that I came up with, which will almost certainly be missing certain places, but I was looking at main academic centers. So you see the star colors here represent the name of the program between interventional psychiatry, neuromodulation, or in blue, neurostimulation, brain stimulation, neurotherapeutics. There's a whole bunch of other terms that are used. And 2025, I tried to update this earlier this week, and it actually got overwhelming. So if you see no star at the place you're coming from, please put it in the chat at the end, and I'll add you to my map here. But this is very admittedly a non-exhaustive map, but you see a lot more yellow stars. A lot more people are going towards the interventional psychiatry title. All right, so for people who have been involved in this the alphabet soup of interventional psychiatry, especially on the neurostimulation and device side of things. So this was, again, just kind of a list of 3- and 4-letter terms that are often used in the literature, often used by interventional psychiatrists. And so maybe you recognize some of these, maybe you recognize none of these or all of these, but the goal here is to make these kind of secondhand knowledge to you, so you can start thinking about what these different acronyms mean, but even more beyond that, like what do these different modalities do? When would I recommend these? What are the physics behind these? Those are all questions we hope people will come away from with this lecture series. And so this was something I made, admittedly, kind of bad graphics here in terms of the animations. But one way you could think about it, there's a lot of ways you can waste bucket these terms. And I think sometimes how you organize these can help you understand the differences between them. So as Dr. Giacobbe mentioned, a lot of these are electrical stimulation treatments like TDCS or transcranial direct current stimulation. TES is just a broader umbrella term for electrical stimulation. There's alternating current stimulation, ECT, deep brain stimulation, vagus nerve stimulation. Then we have magnetic treatments or electromagnetic, where a magnetic field is being used to induce a depolarization of neurons electrically in the brain. And then we have things like focused ultrasound, which is entirely, ultrasonic waves, which is so crazy to think about. You can think about the treatments that require anesthesia to undergo the procedure. You could think about the treatments that are surgical in nature, where you're altering the structure of the brain, as Dr. Giacobbe mentioned. Treatments that involves inducing a seizure. And then I think one of the main ones to think about is focality. So TDCS is often very non-focal, although there's now ways that are being developed to make TDCS more focal. TMS gets a little bit more focal. ECT, obviously very non-focal in terms of the stimulus. Again, with some things like FEAST or focal electrically administered seizure therapy that are trying to make ECT more focal. DBS and VNS getting even more focal, and then focused ultrasound, which is, again, like sometimes a millimeter lesion in the brain. So another way to think about it from a practicality standpoint for patients, you often think like, what's this going to cost my patient? Or the hospital will say, what's this going to cost me for you to start an interventional clinic? You could think about FDA indications, which is also a really important way to think about this. And so if you take FDA indications, this is updated as of last year, so I don't think too much has changed. But, when I first started making this list, I was thinking, oh, there's not that many FDA indications, and put this together easy. But if you actually go through the literature, an FDA indication does not always mean that it's the best level of evidence, but it's a bar we have to clear in the US at least, right? And there's a lot. There's a lot of deep brain stimulation indications, ECT, TMS. So, if you're starting this clinic, you are thinking about a lot of different conditions beyond just depression, which I think is really the bread and butter for a lot of interventional psychiatrists. And this list is just going to continue to grow. I know several TMS companies have things that are currently being considered for new indications. So this list could grow even next year. And again, what should I be thinking about when I'm hearing one of these lectures? These are the things that I think you should think about for your patients, and just concepts that go across all of these interventional modalities. So what are the indications I can treat? What's the safety of this device? What are the side effects I should be thinking about? What's the target that I can stimulate with this? And what's a measure of target engagement, if one even exists for this, which sometimes gets into the device physics, the stimulation properties. As Dr. Giacobbe mentioned, you can use TMS and you can inhibit brain activity or you can excite brain activity. You think about time to response, the comorbidities or patient preferences, and also barriers to care that are all going to play into how you think about what a patient may have access to, what they actually need, and kind of how to, in some ways, marry those two things together. All right, and this is a draft, so this is not meant to be something that you should take a picture of and go study later. But this is kind of one thing we're actively working on in the brain stimulation world specifically, which is the development of a brain stimulation fellowship. And so these are kind of just general concepts that really will go across all these different modalities in terms of thinking about the knowledge and application or knowledge and comprehension of these devices, what's the actual physical hands-on application of these, and then the synthesis and evaluation of whether patients get better. All important things to be thinking about. So with that, I'm gonna stop and we can take some Q&A. I put up some questions here mainly to just like spark some thinking or some comments from people. I think Peter and I are both willing to take questions directly, or if people want to just comment on some of these things. I think both of those would be really interesting ways to go with the time we have left. So.
Thank you so much. Feel free to type in the chat, even raise your hand if you would like to contribute something.
Be specifically interested if people don't like the name interventional psychiatry. You should speak up now before it totally supplants every other name.
Yeah, so maybe we could talk about that. Yeah, so in terms of how things have evolved. So I remember when we were trying to propose the area, and we talked about neuromodulation, and the CBT therapists in our area said, hey, I modulate the brain too. And it's true, right? So people, developing treatments that are going to affect change in the brain are modulating the brain. So, and okay, well, that's true. But what's different about the procedures we do? And then, the idea about brain stimulation, which is, talks about the brain and what we're doing with it, came to the forefront. But then we know some treatments are not stimulatory, right? So we can give inhibitory protocols and other things. So maybe that didn't capture the whole thing as well. So then interventional psychiatry seemed to fill that void and be more inclusive, but it's not definitive. People may have different ideas about what to call this field. But I think what we all agree upon, it's the application of energy and procedures to affect positive change for our patients. So that's happy to take some questions and some thoughts from the audience about that.
Looks like we have a question from Jacob. I'll go ahead and allow your microphone and camera if you'd like to share with the group.
Oh, wow. I did not know that I'd get to come on screen. Hi, yeah, Jake Feigl. I'm medical director for interventional psychiatry here at Duke. And we've got, some folks interested across departments and whether we could put together, a fellowship of neuromodulation across, neurology and neurosurgery. Sometimes that feels kind of unwieldy. So I'm just curious what other folks have had in terms of experience with setting up fellowships, and where does the funding come from something that's, I think, not, accredited at this point.
Yeah, I'm happy to comment on that. So we've been thinking about this ourselves too, and we have a fellowship here that's actually philanthropy funded, and the philanthropy funding is time limited. So it's like we've been thinking a lot about what do we do next? When this funding runs out, are we going to be able to get more? I can say only from my limited experience with it, but I know there are ways to I think be creative about getting fellowships that are funded by the clinician billing, like fellow billing. Obviously, they then have to see some of their own patients, but some hospital systems are on board with that. And sometimes, you can still provide the necessary oversight, but have the fellow billing, especially in things like TMS that don't always require a ton of hands-on time once you have a good trained technician. So I think there are ways to do that. But it's a huge challenge, yeah, especially even that brain stimulation fellowship I mentioned, even when that gets an accreditation. It'll be through the United Council of Neurologic Subspecialties, which will not have any funding that's going to go to these programs to offer this. So people are still going to be having to think of creative ways to fund these fellowships. And that goes for everything else that's non-accredited through the ACGME. So yeah, I feel your pain, and those are the things we've been thinking about, but if others have thoughts, I'd be interested as well.
I really like the idea of people coming to this from different educational backgrounds. It could be neurology, it could be other backgrounds. I think the challenge, though, is if you have people coming with different skill sets, what are the common outputs for something like this? So, for example, if we're doing something that is going to look at DBS, are people from psychiatry backgrounds going to have some expectation to do those surgeries? Are people from neurosurgical backgrounds going to develop some basic competency in supportive care, CBT? So I think there's some challenges there, but I really like I agree with Dr. Trapp. Like, these are just disorders of the brain, whether we call them neurological disorders or psychiatric disorders. So to have some kind of common language is important, but I think practically we probably have to walk with interventional psychiatry as a subspecialty before we run with something that is a brain medicine sort of transdisciplinary fellowship.
Thank you. I want to highlight one comment from the chat, and then we have a question from Alan Lee. Jeremy Chakind says, I completed my fellowship at MN, and it is designed to potentially take fellows from psych, neurosurgery, and PM&R. So that sounds like one example of an interdisciplinary program. We also have a question from Alan Lee, a former classmate of mine. Let me find you so I could unmute you if you'd like to share with the group. One moment. I'll allow your mic and your camera.
Oh, hi, Yaakov. So great to see you. Amazing.
Good to see you too.
Thank you so much for the opportunity. I was wondering in terms of like what makes you guys, I'm just wondering what makes you guys feel like this should be more of like a fellowship thing versus like more of a push to incorporate this training as we call it to like to the sufficient competencies at the residency level, given that the residency for psychiatry is long, the field is like suffers from poor revenue streams, and this could be especially because other like it's all about turf wars in terms of like attempting to capture revenue streams, like, and that this is the creation of new revenue streams for the field. Like why not like push this at a level that like allows access to like to train for trainees who have access to it, be able to increase the field's financial solvency issues, and versus like I guess like pushing it towards a fellowship level and possibly like losing out on that ability. I think one thing I was also wondering, and second of all, as a practical clinical question was, how do people in practicing interventional neuropsychiatry screen out people with personality disorders? Is that do you rely on like the primary psychiatrist to do so, or is there their own evaluation?
Yeah, I'll comment on your first question first, and thank you for both those questions, by the way. To be clear, and I don't think I made this clear, that I don't think that this needs to be a fellowship. I think that there is the ability to gain additional experience in a fellowship that could be useful, especially for some people who may not get this in their residency training. However, I totally agree that this should be incorporated for residents, and I think that psychiatry trainees across the board should get experience with this. I do think there's going to be some more complex cases. For example, managing deep brain stimulators, the patient volume just isn't there for people to do that regularly in a lot of clinics. And so I think there will be some subspecialized parts of interventional psychiatry that may require fellowship or at least additional experience. But a lot of this, especially things like administering esketamine, doing TMS for pretty standard treatment-resistant depression, that's just like, that should be basic psychiatry for everyone. And I totally agree that, this should be just things we all incorporate, and you may get better at certain parts of psychiatry from the experiences you get. But I do not think this needs to be a fellowship. Fellowships will exist, but I don't think it needs to be.
Yeah, I totally agree. From the data that we showed, that people already see this as part of their identity. And I think it's also important to note that there's basic and advanced competencies. I mean, we all go through psychiatry training and do CBT, and to be really good at CBT, you got to do more training. So we would hope that this is incorporated for everybody and people have at least basic competencies. And even if you're not an interventionalist or a practitioner in this area, you've done enough training where you know gestalts and phenotypes of people who would respond to the treatments, and then to refer them on. So I think at a basic level, that could be incorporated. And then if you want to do advanced training with more specific techniques, perhaps a fellowship could be thought of there. To come to your second question about personality disorders, I think this is an important question. Definitely, because sometimes people who come to us with treatment resistance gets conflated with the idea of difficult to treat, right? Somebody with, needs interventional care is not always somebody that, we have to determine that have they not responded to treatments for other reasons versus just the fact that, you've been on 6 medications, we're going to send you to an interventionalist, right? There has to be a clear indication for that. And that's something that I think is a shared responsibility from the referring doctor, as well as when you screen these individuals. Certainly for the more intensive and invasive procedures we do, the surgeries, it's a multi-step program. It's you see somebody 3 or 4 times before making the decision. And so perhaps when things are more invasive and there's more concern about potential side effects, slowing it down and determining if that's playing a role in the treatment resistance is really more important.
Thank you. We have 2 somewhat similar questions in the chat that I'll combine. Scott Burns asks, are there opportunities for psychiatrists already in practice to become competent in interventional psychiatry without pursuing a formal fellowship? And Brandon Liu asks, what does a position in interventional psychiatry look like? What does the job market look like, either with or without additional fellowship training?
Want me to take a stab at that? So regarding additional training, there's absolutely lots of stuff out there. So, I know TMS best, but there's several institutions, Harvard, Medical University of South Carolina, several others that have, University of Toronto, that have training programs that are sometimes like a week long, a few days long, to just get you like basic concepts, hands-on exposure to equipment. There's ECT courses that sometimes run with conferences as well. So there's a whole bunch, that's kind of from a hands-on perspective. There's a lot of those types of courses that are more than just a manufacturer giving you information. It's clinicians being involved in talking about the practice of utilizing these treatments. And then, like I said, we have a residency track here. That's not everywhere, but we do take visiting residents for that. So there's other places that will offer that type of thing. And then I know there's also just videos, like YouTube videos. I know NIMH and Holly Listenby have put out like TMS videos that anybody can watch for free. So there's a lot of information out there if you know the right places to look.
Yeah, here at University of Toronto, we wanted to come up with something a separate stream. But what the feedback we got was, start off with a certificate. Get people hands-on experience on the things that they need the most: EC, TMS, ketamine, other things like that. 6-month experience. So I think it's possible for people already in practice, if they can carve out some time, to again develop core and even advanced competencies within that period of time. So I think that's when we start off. We're going to start off with a certificate, and then obviously advanced training. There's a lot of comments in the chat that absolutely, if you want to be in academics in this area, you probably need more advanced training. But for core skills, I think weeks or months certainly would get you there.
Thank you so much for sharing, and thank you everybody for attending and for your questions. And with that, we will conclude our talk today. Dr. Giacobbe, Dr. Trapp, thank you very, very much. And everybody, we hope to see you next time. Sign up and take our survey to stay in the loop, and we look forward to being connected.